Welcome to everyone. Tonight, 48th Zoom, what a success that's been, and our 180th event. Sorry to go on about this, but one takes a certain degree of pride in having such fantastic people like you participating in events like this. And as I say, the program goes on and on. But in fact, the reason we're together in this order is the pandemic. And heaven knows whether we get an announcement on Monday that the things will ease or not, we don't know. Now, I was watching the excellent series Hospital last night, brilliantly done from Coventry Hospital, deeply moving as always. And of course, in a sense, we're looking at what's the knock-on effect of the pandemic. And quite clearly, cancer care, the Crossroads, it couldn't be more timely. And in relation to this, I couldn't have two greater experts within their field. Maybe I slightly gilded the lily as I was gently told off by Mike last night, practitioners. But in fact, of course, we've got two great experts within the field. Mike Meyer, founder and president of the Meyer Consulting, headquarters in Arizona. As I said, Mike's coming in from New York tonight. We're privileged with that. And Professor Richard Sullivan, who's Professor of Cancer and Global Health at King's College. Now, I sent out something about their CVs. Time is precious in relation to this, but I can assure you, ladies and gentlemen, we couldn't have better people in the field. And I hope there are going to be loads of questions. I know I've got things which I want to ask later. I'm sure Bob feels the same way, but in the end, it's the audience. So without further ado, welcome to both Richard and to Mike. And can I, Mike, ask you to start the ball rolling, please? Lovely to speak to you.
Sure, Steve. Thank you again for having us. It's great to be doing with my friend and colleague Richard, and it's great to see all of you. Even though I wish we were doing this in person, but Zoom, we've all become, I think, Zoom experts. I guess what I want to do is part is to have this more of a discussion than a speech. Both Richard and I really enjoy this format. We'd rather do Q&A than go on and ramble for a while. So I'm going to keep this pretty short. And we're going to show you a couple of slides, but if you want them, just let Steve or Bob know and we can send them to you, but they're not really all that important. I think much more important is the discussion and hear what your questions are and what your views are, because there's far more that we don't know than we do know. So I wanted to just start with a personal story first. It amazes me sitting here in New York that I haven't been on a plane overseas for, I can't remember how long. But anyway, one of the fondest recent memories, and I visited your country many times, was in 2018 when my daughter was studying at King's College and I was working in London on a project. And we were in a pub and we were watching you guys play in the World Cup. And, you guys were doing a phenomenal job. And I was sitting in a pub cheering with everybody. And when I think of that, I think back on how the world has changed since that World Cup. It's just unbelievable. And the good news is that I think the sun is coming out. I think we're coming out of this nightmare. And probably the most important thing you should take away as an American on this call is that I will be rooting for you guys again in 2022, just so you know, because we're going to be terrible again. So, and hopefully you guys will be terrific. On the more serious note, back in the beginning of the pandemic, I wrote an op-ed in the Wall Street Journal where we made it was with a colleague of mine, and we made some predictions which have turned out to be remarkably accurate, unfortunately. And one of the things that we talked about was that we felt that you're going to see this aftershock or this third wave of sicker people because of COVID, because of the delays in going to doctors, because of people being worried, because of economic stress. And that's actually playing out. Unfortunately, we are seeing that over and over, in not only in cancer, but in other areas. We're seeing it in mental health. And so if you look at just cancer specifically, and Richard can speak obviously far more eloquently about this because they've done some phenomenal research at King's College and with his team and other people on some of this pandemic related cancer numbers. But to put it in perspective, there are about 1.6 million new cancer cases in the United States each year. About 600,000 Americans die of cancer. So if we have a stage migration where people are being diagnosed later in their cancer and the cancer is already metastasized or spread, which is happening, you could see a substantial, and we expect that, a substantial increase in the number of deaths. And that's sad. Now, it may not be entirely the case that happens, because the cancer treatments and the way people are holistically approaching it today has gotten better. But I do expect, and I think Richard would agree, that we're going to see mortality rates, go up. And it's interesting, if you go back 100 years ago to the Spanish flu, the mortality rates were coming down dramatically in the years before 1918. And then when the Spanish flu hit, you had this spike, which is what you would expect from people who died of the Spanish flu. And, and then, the question really is, and of course the data isn't great then, what happened after that? So I think there's a lot to discuss today. Steve, I just want you to know, I think the Leaders Club is remarkable what you've done. I don't know anything in the United States that's like this. And it does something that I think is exceedingly important, which is to cut across all of the stakeholders, not only in the medical community, but in all other industries. All of you have healthcare needs. You all have families. You have employers. You have employees. And this cross-pollination of concepts and ideas is so important. And I think, and I'm not going to get into politics tonight. I'll probably dodge the question if somebody asks me, but I think organizations like the Leaders Group are even more important, given the fact that so many of the organizations that we've relied on in the past have been more politicized, and organizations like the WHO and the CDC. There are just a lot of issues. So when you have organizations that are not for profit, that are bringing together people, the Leaders Club, I'm involved in two that I think will have a substantial impact that are private. The Human Health and Research Foundation, which is based in London, Institute for Mental Health Research, which is based in the United States, which is seeing a dramatic increase in mental health issues. So I actually think organizations like the Leaders Club will actually play an even more important role in the future. So let me just turn for a second on where we are today. Bob, if you would put that third slide up, that would be, and I'm not going to pontificate for too long on this, but if you're able to put that third slide up, there are really four areas that Richard and I wanted to talk about, and obviously answer any questions that you have. The advances in cancer science and treatment, I'm going to defer a lot to Richard on this, but it really was stunning before COVID, and it's even more stunning as we've gone in and gone hopefully past COVID. In America, there are two things that are going on that are facilitating this. One is that the huge amount of expenditures in research on COVID is gonna slosh over into cancer. You'll hear talk about the mRNA vaccine, the Pfizer vaccine for COVID, and there's a lot of talk about vaccines for cancer. So there's going to be a lot of, I think, a carryover from that, and that's really been remarkable. So you really see that kind of an increase. And then here specifically in the States, there are two other things that are really going to be driving this. One is that President Biden, as I think some of you know, lost a son to cancer, and he's been a big supporter of cancer research. So there will be a substantial, I think, increase in funding in the National Institutes of Health and the National Cancer Institute. And then Dr. Sullivan and I and Steve were talking about this a couple of days ago. I've never seen more activity in the private equity markets where private equity firms are funding startup oncology companies. There are just so many different startups in this country. I can't speak for England, but in America, there's so much private money going into oncology discovery. Now, to give you a little bit of a frame of reference, in the United States, there are roughly right now 4,000 phase 1 clinical trials going on, which is just a stunning number. I mean, and if you've see, you'll see that there are new drugs. You probably read about the Amgen drug. You probably saw the news yesterday about the Alzheimer's approval. So you're just seeing this rapid science movement. And it's not only in drugs, but obviously drugs are the ones that get a lot of the play. The increase in costs, this is something we probably will talk about in Q&A. It's a major challenge. I personally think, and I hope somebody asks this question, I think that price per pill, price per unit is a flawed way to look at costs. I think really we should be looking at total cost of care and quality of the treatment. The impact on COVID is probably something that we should talk about also when we're doing Q&A. There's good and bad. Obviously, clinical trials in almost anything other than COVID came to a complete halt in the United States when COVID hit. Again, I mentioned the issue of the number of additional cases, the number of deferred diagnoses and treatment. But there are also positive impacts that are coming out of this, as I mentioned to you in research. And I think there's also a broader positive that's coming out of this when it comes to how patients are being treated. There, at least in America, there's this heavy move to telemedicine. You don't need to go and sit in your doctor's office with a bunch of sick people and coughing around you and waiting to see a doctor. I actually think there's going to be some really good things that will come out of COVID and the way doctors, at least in America, interact with patients. The social decisions on what we pay for, this is something that Richard and I have talked a great deal about, and it's really a challenge. In the United States, I mean, after age, the number one indicator of how well you do in your cancer treatment is economics, is social determinants of health. Poor people just have better outcomes for cancer than middle class and wealthier people in this country. And we can talk about the difference in health insurance systems, but they just do. And there's a lot of discussion about that in the States. So let me stop there. I'm going to turn it over to Richard. The only thing I wanted to close with, if you go back to the Spanish flu, the mortality rates were coming down substantially prior to 1918. And then you had, of course, the bump. And what's interesting is that if you then look at the decade of the 20s, the mortality rates, at least in the United States, did not start going down until the 30s. So it took a decade of the 20s to recover from the Spanish flu. And the question is, will it take a decade for us to recover from the pandemic in terms of additional deaths, not just due to the pandemic, but what I terribly refer to often as collateral damage? Will it take us a decade, or can we do it quicker? And I hope we can do it quicker. And I don't only mean that in the United States, I mean it in the UK and elsewhere in the world, which clearly is suffering greatly. So let me stop there. My friend, I'll turn it over to you.
Mike, thank you very much indeed. And Steve and Bob, thank you so much for this kind invitation. Well, ladies and gentlemen, let me just pick up where Mike left off and maybe pull back a little bit here. I'm going to kind of try and address what Mike said in terms of the context of the research and the cost issues, but using kind of three metaphors for the pandemic and its impact on cancer. One is the pandemic as a weight on our healthcare and our cancer care systems. Another is the pandemic as a way of illuminating. What is it illuminated about cancer care? And then finally, really, is the pandemic as a mirror to cancer care and healthcare generally. But before I say anything, really, I just want to preface what I'm going to say in those three blocks, really, with just a few opening comments. And the first thing to say is that you have to remember that cancer care really is an apex disease. To be blunt with you, if you're going to achieve really good outcomes in cancer care, good survival, less suffering, it's a composite endpoint of a lot of complicated and complex pathways and systems. And that reflects social determinants. It reflects how wealthy you are. Do you come from an ethnic minority? Are you socially excluded? It reflects healthy aging. That's prevention. You know, have you grown old well? Are you obese or not? Have you drunk too much? Have you smoked? Obviously, that's the classic one. It reflects the state of our public health. It reflects general practice and community medicine, as well as the state of all the generic aspects of our hospital systems, be those diagnostic, surgery, radiotherapy, or indeed general medicine. And I think that's a really important model to keep in your head, because when you think about the impact of a pandemic on cancer, people automatically think of radiotherapy, systemic therapy, surgery. But really what we're talking about in cancer is the entire system of health and welfare. A few general points as well about the pandemic in relation to cancer. The first is that there isn't anything particularly new under the sun about this pandemic. We've had nearly 1,500 epidemics and pandemics in the last 10 years across the globe, and they are growing in frequency. They're growing in frequency because of the way that a couple of things are happening. Firstly, human demography, how we're interfacing with the natural world, and also how the natural world is changing due to climate change, and again, the influence of human activity. And there's also actually nothing special about the coronavirus family itself. This is actually the 7th coronavirus that's jumped into human beings. I was actually involved in the MERS outbreak, and I have to say, if you want to have a very scary coronavirus, that's the one to be frightened of. That had nearly a 35% case fatality rate, and 80% of people, irrespective of age, who caught that ended up in intensive care. The good news of that, of course, is you had to be coughed on directly by a camel. So as long as you avoided camels, you were perfectly safe. The SARS-CoV-2 virus is interesting in and of itself. Its infection fatality rate is actually incredibly low. It's only about 0.4 to 0.5%. If you develop the disease, and remember, most people, 40% of people will not develop the disease. They will just harbor the virus. If you develop the disease, the case fatality rate is about 2%. So when you compare it to other epidemics and pandemics, I've worked in, as I said, MERS before, I've worked in 3 Ebola outbreaks. If you want to be truly frightened, the filoviruses and Ebolas are the ones to really, really scare you. So as a virus itself, it's a relatively normal aspect. And as Sir David Omond, who works in our School of Security Studies as a visiting fellow, has said a number of times, that a pandemic was top of the national risk register in the UK and indeed across most of the Five Eyes and high income countries. And it stood right up there at the top. Yet, to be blunt with you, both from political and a professional and a healthcare service point of view, we were really woefully underprepared. So should we be prepared better as a healthcare community? The answer is almost certainly yes. So let me, having sort of slightly painted a slightly dark picture, let me just go back to those 3 metaphors about the pandemic on cancer. The first is the pandemic as a weight on our system, and there's absolutely no doubt what it's done is created new cracks. Firstly, social determinants of cancer. We've seen widening inequalities growing in cancer and healthcare because of the pandemic. Now, the outcomes of these will not be felt for 10 years or so because of the time it takes for changes in social determinants to change to poor outcomes. But there's absolutely no doubt all the data is heading the wrong way. We are seeing widening inequalities. We're also seeing more cracks between general practice and our hospital system. Myself and my other colleagues have been lamenting about this cracks opening up in the system for years. This has actually just created even more cracks. It's also cracked the system within hospitals as well. What we're seeing at the moment is, as you'll read from the papers, huge backlogs, particularly in diagnostics, particularly in surgery. And I also want to just point out within those backlogs as well, we are still missing 40,000 people that should have been diagnosed with cancer up till now, who should have been diagnosed from February up to now with cancer, who have still not entered the system, and we just don't know where they are. And the reason that is because majority of people, about 40% of people, are actually picked up routinely, accidentally, because they go to their GP, because something happens. They interface with the healthcare system in a different way. Those people are missing completely. They just haven't entered our system yet. So that's a big problem. It's the weight of the pandemic. The second is the issue of illumination. I think the pandemic's shone a really harsh spotlight on a number of issues in cancer care and research. I think that remained relatively in the shadows until now. Firstly, we were really poor in mitigation and developing rapid countermeasures. We're a hell of a lot better now, but I can tell you at the beginning, we were all over the place. Partly it's because the scientific process, and it alludes to what Mike was saying about research, was not up to the job of providing rapid, actionable intelligence for us to develop systems to mitigate the risks to our patients. And a lot of the early data that came out sent us completely in the wrong way. Yeah. It's also really, I think, exposed some really big problems here in terms of delays in diagnosis and what delays in treatment means to outcomes. We published 2 very unpopular papers which kind of illuminated what this was going to mean for England. When you look at the delays in diagnosis for England alone across 4 cancers, we're going to see now, and this will come to pass no matter what, about 60,000 years of lost life over the next 5 years because diagnosis has been delayed. Treatment delays are equally terrible. What this means economically, and it goes back to what Mike's talking about, is we think a lot about the cost of pills. We always talk about the economics of cancer, the cost of medicines, the cost of robots. But of course, productivity losses due to premature mortality and morbidity have huge impact on our economies. A paper we just published in the European Journal of Cancer basically shows that if you look across the United Kingdom as a whole, over the next 5 years, premature mortality alone from cancer will cost the United Kingdom economy somewhere between 750 and 1.2 billion pounds. It's a massive sum. So you can imagine how this is being replicated all over the world because we're not alone. This is happening in the United States, in France, in Italy, etc. Mike also talked about the movement of private equity into the research system. I think another uncomfortable fact it's shown us with the pandemic is that we spend a lot of time doing research on therapies, on medicines, on surgical techniques, on radiotherapy. We don't do half as much work in understanding how to embed those new technologies in our systems, how to make them equitable, how to make them affordable, how to make them sustainable, particularly, and this is, I think, the counterbalance here to the US system, particularly if we believe in the NHS and we believe in the idea of equity, free at point of care for all, and a sustainable health service. And that's something we really had to face up to a great deal. Finally, Mike, just to make the comment about the mirror issue. You know, you can use the pandemic within cancer care as a way of sort of looking at ourselves in the mirror. And again, I think it's reflected some uncomfortable truths about political, public, and professional behaviors in the crisis that I don't think we've yet fully addressed. There's a huge amount of disenchantment and burnout in lots of sectors. It's interesting because last year the OECD produced one of their major reports called Healthcare 2020, looking at high-income countries' healthcare systems. It's well worth reading. The UK comes out worse than any other healthcare system because we burn red hot all the time, even in normal times. And we burn red hot all the time because we have too few beds, too few nurses, too few doctors, and too few of every flavour of healthcare professional. And there's not a single Royal College president who wouldn't agree with me on that. But my point about that OECD report is it reflects the fact that we burn hot in non-pandemic times, never mind when a pandemic comes along. I think the pandemic has also reflected, I have to talk about politics, I can't avoid it being a doctor.
Here you go.
Here we go.